Hi, thanks for joining me today. My name is Arlene D'Souza. I'm a hematology and oncology physician at Northwestern Medicine Regional Medical Group. I'm here at Living Well Cancer Center, which is part of Northwestern. It has over 100 programs and services that we offer for free to our patients. And today I'm going to be talking about blood cancers. If you have questions during any time, please just post them in the comments section and I'll answer them if time allows. So today we're talking about blood cancers, and sometimes they're called hematologic cancers. Most of the time they start in the bone marrow, which is where blood is produced. So what exactly is blood? We all know it, but sometimes we don't know the parts of it. So the bone marrow makes blood, which has red blood cells, which are the cells responsible for transporting oxygen to our lungs and throughout our tissues. It makes white blood cells, which help our bodies fight infection and keep us safe, and it makes platelets, which help clot our blood and prevent us from bleeding. So what is blood cancer? So blood cancer is essentially disordered production of cells within the bone marrow. So it's essentially the bone marrow not making cells the way it should, which can leave people more susceptible to infections and cause them to become ill. So this is a wide basket of terms for a variety of different cancers, but for today's talk, we'll talk about leukemias, lymphomas, and multiple myeloma. So leukemia is a cancer of white blood cells in the bone marrow, and often it's a cancer where you make too many white blood cells. These cells are often abnormal, and what that means is that they don't do the job that they're supposed to, so they don't protect us from infection the way that they're supposed to. There's several different types of leukemias. There's acute leukemias and chronic leukemias. Acute leukemias are more aggressive, and they tend to need to be treated more aggressively subsequently. So we often use chemotherapy and things like stem cell transplants for those patients. And then there's chronic leukemias. So these make more mature white blood cells, but still too many of them. So we don't have to treat them necessarily as aggressively, but they still require a lot of care and a lot of treatment. Potentially not stem cell transplants, but they can be treated with pills often and different types of chemotherapies. Another type of blood cancer is lymphoma, so that's a cancer of lymphocytes. Lymphocytes are part of our lymphatic system, so they protect our body from infection. Lymphocytes travel throughout the body through the lymphatic system, and particularly through small bean-sized structures called lymph nodes. These lymph nodes filter harmful substances from our body. So often if you make abnormal lymphocytes or too many lymphocytes, you might see abnormal lymph nodes. They might be enlarged, and this again increases our risk of infection and makes us more susceptible to infections and illnesses. There's two different types of lymphomas that most people have probably heard about. One is Hodgkin's lymphoma and the other is non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is much more common than Hodgkin's. The major distinction between the two of them is something called a Reed-Sternberg cell, which you see in Hodgkin's lymphoma rather than non-Hodgkin's. So this causes us to treat it with different chemotherapies. But again, for both of these treatments, you use chemotherapy. We often use radiation therapy for the treatment of lymphoma. And then the last blood cancer is multiple myeloma that we're going to talk about. So it's a lymphocyte disorder so it's a cancer of plasma cells, which is a type of white blood cell disorder. And plasma cells make antibodies to help us fight infections. So if you make too many plasma cells, this increases our risk of infections. And often we need to be treated with chemotherapy, which can be in a variety of ways. And sometimes if these plasma cells get embedded in the bone, it can cause bone problems. And sometimes we do radiation therapy to these areas where there's too many plasma cells in the bones. So people often ask, what are some risk factors? Why do some people get blood cancers? And although it's not completely known, it's most likely a combination of both genetic and environmental exposures. So the things that cause other cancers can cause blood cancers too. So that can be things like smoking, radiation exposure, and exposure to harmful chemicals such as benzene Certain viruses can also increase your risk of blood cancers. So those can be viruses such as HIV or Epstein-Barr virus. So if somebody has blood cancer, what are some symptoms that they might have? So they could have fatigue, they could have unintentional weight loss, certain things like night sweats, which we usually describe as drenching, meaning you wake up at night soaked with sweat. You might need to change your clothes or even change the sheets in your bed. People might have weakness, bone pain, or they might wake up, or they might have symptoms of easy bleeding and bruising. So sometimes abnormal signs of bruising would be kind of waking up, seeing bruises on your body and not having done anything to cause them. Sometimes people have enlarged lymph nodes that they notice, and lymph nodes can be anywhere. We most often notice them in our necks, but they can be under our arms, in our chest, in our groin, and you can even have things like an enlarged spleen or an enlarged liver. Most people don't know what that might feel like, but some symptoms of something like that would be abdominal distension, something called early satiety, so meaning you might feel full even though you're not eating as much as you normally would, just a general sensation of feeling bloated. And sometimes people can even see that their abdomen looks swollen and abnormal. So if you have these symptoms, some people wonder then how would you get a diagnosis of a blood cancer? And the way that some people do it is when they go to their primary care doctor and they get routine blood work, what they find is that their routine CBC or complete blood count is abnormal. So what they might find is that they have a very high white blood cell count. They might have abnormal appearing white blood cells seen on their routine blood smears. You might be anemic and not have a clear explanation why, or your platelet count might be very low. Other ways that people might find out that they have blood cancer, such as lymphoma, are swollen lymph nodes that potentially don't go away after a certain amount of time. They might have imaging done that shows enlarged lymph nodes, and then so that imaging would be something like a CT scan or a PET CT. And once your primary care doctor or doctor who's kind of identifying some abnormalities in your blood work or kind of investigating these symptoms that you have, notice that there's an abnormality in your white blood cells, an anemia, a low platelet count, abnormal lymph nodes, the next step that they would do would be something called a bone marrow biopsy. A bone marrow biopsy is essentially where they take a needle and they put it in the back of your hip bone. And we would draw a little bit of the inside of that bone, which is where the bone marrow is. We send it to our pathologist who analyze it and look for abnormal cells, and that is how you would diagnose a leukemia. If for a diagnosis of lymphoma, what happens is you would need a biopsy, and usually a surgeon or an interventional radiologist would do it, where they take a needle, either put it into the lymph node or actually take out the entire lymph node. Again, we would send it to our pathologists, and they would look at it under the microscope, and they would then see those abnormal cells, which would lead us to our diagnosis. Multiple myeloma is diagnosed in a similar way, where you would get a certain amount of blood tests that would show abnormal proteins and abnormal plasma cells. You would confirm it with a bone marrow biopsy and get certain imaging, like a PET scan, to make sure that there was no evidence of abnormalities elsewhere in the body. Are there any questions yet, or should we?
I can go ahead and ask some.
Well, I can keep going and talking about treatments.
Absolutely.
Okay. So how do we treat these different blood cancers? Well, I've sort of touched on it as we've gone through, but chemotherapy. So what chemotherapy is basically can be intravenous or oral, and that's essentially medicine aimed at killing your cancer cells. Unfortunately, it tends to be non-specific, so it can kill some of your good cells as well. But in our blood cancers, it's been very successful in terms of getting control of disease. Other types of therapies could be radiation therapy, where they use high-intensity rays aimed at enlarged lymph nodes to kill certain sites of cancers. Like you often see that for multiple myelomas and lymphomas. We have targeted therapies, which are really nice that we have kind of in the more modern era, and essentially those are medicines that target the specific receptors of our cancer cells, and they are able to attack those cells specifically and kill those cells. And then we have immunotherapy, which uses our body's immune system to fight cancer cells for us. Previously, we also have stem cell transplants. So what stem cell transplants do are they use stem cells that don't have cancer in it, and they infuse them into a patient's bone marrow and essentially allow a patient's bone marrow to be repopulated with good cells, and those cells can then make normal white blood cells, normal red blood cells, and normal platelets. There's two types of stem cell transplants that we sometimes consider for people. One is called an autologous stem cell transplant, which means that you're using your body's own stem cells, and those are being infused into you after you've had some sort of treatment to get rid of the cancer that's already in your body. The benefit of an autologous stem cell transplant is that it's your body's own stem cells, so you tend not to react to it. They repopulate your bone marrow relatively quickly, and you don't have allergic reactions to it. Like, there's no evidence of graft versus host. Allogeneic stem cell transplants are used in certain situations, and those are other people's stem cells. So essentially, they find other people's stem cells that are relatively well matched compared to your body's own stem cells, and they infuse those back into you so that you can repopulate with a normal population of cells if your own stem cells aren't available to do that.
Okay. If I have a blood cancer, what type of doctor or doctors do I need to see for care?
So you would see somebody like myself, a hematologist or oncologist. Essentially, that would be the person that it guides you through this process. So it can become a complex process where you would see the oncologist. They would kind of assess you. They'd assess your blood. Based on that, you would get some sort of biopsy or bone marrow biopsy, which a pathologist who you don't necessarily see would review the cells and make that diagnosis for you. Radiologists are also included in doctors that you don't necessarily see. They look at your imaging, they kind of assess abnormalities and help guide the hematologist and oncologist as to where your disease is and how best to approach it. Other doctors that you might see would be a surgeon if you need some sort of excisional lymph node biopsy or a biopsy of another part of your body, and a radiation oncologist if radiation is part of your therapy. And those are the doctors that would take special scans of your body. They would locate the sites of the disease. They would actually map out the specific areas that they would aim those X-ray beams at, and they would be kind of part of the team in treating your blood cancer.
Chris is asking, what is CAR T therapy?
So CAR T therapy is the most exciting kind of treatment that's happening at this time. It is when we take the body's T cells, which are a type of white blood cell that help fight infection. They take a population of them, they remove them from you, they send them off to a lab where they're modified and essentially altered so that they fight your cancer cells, and then they reinfuse these cells back into you. So it's a very exciting topic in medicine right now, and essentially it's allowing you to use your own immune cells to specifically target cancer cells. It's FDA approved for ALL in patients who are less than 25 who have failed other forms of therapy, and it's also approved right now for people with non-Hodgkin lymphomas who have failed a few prior lines of therapy, and the results that they're getting are quite excellent. So it's certainly an exciting time, and there's constantly new trials going on to see if there are other cancers that they can apply this type of treatment to. I know there's a lot of trials in multiple myeloma right now to see if CAR T therapy is successful in it.
While we're on breakthroughs, what is genomic testing for blood cancers?
Genomic testing is another new aspect of treatment for patients, and it's based on the idea that everybody's cancer is unique to them. So everybody's DNA profile of their cancer has certain mutations or changes that cause their cancer to grow. So by doing genomic testing, sometimes we call it next generation sequencing, we're analyzing a patient's cancer cells, we're finding out what those mutations are, and that way that'll give us more information to see if they're eligible for specific targeted treatments for their own specific mutations.
In talking about this, is it a good idea for a patient to get on a treatment, to get on a clinical trial for treatment?
I think clinical trials are great, and I think that living in the Chicagoland area is a unique opportunity for patients because it gives you access to really exciting therapies that may not be FDA approved yet. I think that we have a lot of really good academic institutions here that have a lot of really exciting trials, so I think that everybody early on in their diagnosis should see if any clinical trials are available to them and if it sounds like something that they would want to do.
And Deb's asking, with the different types of blood cancers, what typically are the prognoses, and are the prognoses or survival rates improving?
They're certainly improving, and that's another reason that treating blood cancers is so gratifying. So we kind of touched on earlier that there's acute leukemias and chronic leukemias. In acute leukemias, there's new therapies now that are actually targeted therapies. So in addition to the standard chemotherapy and in addition to stem cell transplants, if people have certain mutations seen in their cancer cells, we have targeted therapies that are available to them that actually improve outcomes. And in our chronic leukemias, we're having a lot of, especially CLL, there are a lot of new targeted therapies and chemotherapies that are really prolonging people's survival. They're prolonging the amount of time that their disease is very well controlled. And in the chronic myeloid leukemias, people are living a very, very long time on oral treatments. So in terms of the leukemias, people are doing well, and the survival is improving all the time. In terms of lymphoma, we have patients with Hodgkin's lymphoma, which is traditionally the survival is excellent for those. We also have our patients with non-Hodgkin's lymphoma, which I think we should maybe pause and talk a little bit more about because it's a wide spectrum of diseases. It can be, as I said before, it's a disease of lymphocytes. It can be B cells or it can be T cells. And the spectrum of disease can vary from really indolent, meaning not very aggressive, to very aggressive. So for people with the more aggressive non-Hodgkin's lymphomas, there are new treatments. Like I mentioned, there's CAR-T, which is we're having really exciting outcomes with, and there's also new targeted therapies that we're regularly using that are improving survival, and it's wonderful to see.
So a two-part question regarding multiple myeloma. Dennis is asking, are there any new treatments in the pipeline for multiple myeloma? And Chris is asking, can you cure multiple myeloma?
So there are a variety of new treatments in the pipeline for multiple myeloma. They're kind of coming out all the time, but in kind of real time for what's FDA approved now, we have a lot of targeted therapies that we're having excellent results with at this time, and people are seeing that their disease being controlled for many years, and because there's so many of them, what we're seeing is that we can use one agent for an extended period of time, and then we'll have a lot of other agents that are still available to use. Some of them are monoclonal antibodies, some of them are third or fourth generations of drugs that we already have. We're doing different combinations of drugs together that are providing a lot better outcomes for people. And then there's things like, CAR-T trials that we might potentially see in the future to even offer more options to our patients. In terms of can multiple myeloma be cured, the short answer is no, but what we are finding is that we can keep people with controlled disease for an extended period of time, and that amount of time that people are disease-free or with controlled disease is much longer than it was 10 or 15 years ago.
Again, Chris is asking, my mother was diagnosed with lymphoma, and the doctor told patients need treatment and some don't?
So I sort of discussed this a little, or touched on it a second ago, but essentially there are a variety of lymphomas. Some can be very aggressive and some are on the spectrum of not being aggressive. So an example of a lymphoma that may not be very aggressive is called follicular lymphoma. So depending on how advanced this is, it might be something that we can watch. So for example, if someone with follicular lymphoma might have a few enlarged lymph nodes in one or two spots on their body, they're not necessarily having symptoms. Those lymph nodes aren't necessarily growing. So if the diagnosis is follicular lymphoma, it's something that we can watch without treatment. We can just consider, surveillance imaging every few months, checking their labs. They check in with their oncologist every 3 to 4 months, and based on that, decisions can be made in real time whether or not they need to be treated. But many people can go years without needing to be treated.
Okay. Why did you become a cancer doctor? Isn't it hard?
I think that my reason for being a cancer doctor is probably similar to a lot of people's. I think that cancer is a diagnosis not only for just a patient, but also for their whole family. And it can really affect somebody's life in terms of kind of what they think their future is and how long that future is for them. So I think that as an oncologist, you're given a unique opportunity to really care for somebody and help them navigate through a really challenging time. And on top of that, you get to there's a lot of really interesting science behind it. So there's all of these new drugs and new trials that we can kind of use to help make patients' lives better and their families' lives better. So in terms of the academic side of it, I think it's very interesting. And I also like the aspect of kind of being there to navigate patients and their families through potentially one of the most challenging times in their lives.
Deborah's asking, my mom had mantle cell lymphoma. Will I get it as well?
So at this time, there's no clear link between, no clear genetic link. There's always some component of, if there's multiple family members with certain lymphomas, then I think that there would be a benefit to seeing a genetic counselor. But at this moment, there's not one specific mutation that's passed down from generation to generation that would potentially make her at more risk than another person.
If I get sick and have swollen glands, does that mean I have lymphoma? And how do I know that I don't?
So swollen glands are our lymph nodes getting enlarged, and they're the site where our our lymphocytes go to kind of help filter the blood and clear it of infection. So when our glands get swollen, that means that our lymphocytes are kind of doing what they're supposed to do. They're congregating to a certain area where that potentially has an infection, and they're working hard to protect our body. So when you're sick, swollen, tender, enlarged glands are actually a sign that your body is doing its job in protecting you. The time to get concerned is if you have persistently enlarged glands in the absence of an infection that don't go away and increase in size over time. And if you do notice that, then that would be an opportunity to talk to your primary care doctor. And if they thought that it was abnormal, the next steps would be maybe getting an imaging to see if there were other enlarged lymph nodes throughout the body. And then it would be and if they did find that, or if this lymph node appeared suspicious on imaging, the next step would be some sort of biopsy to look at those cells and make sure that they're not abnormal.
Nancy is asking the question. She has high B-cell lymphoma, and after chemo, her doctor is considering giving her chemo in the spinal cord. Is this effective to keep cancer from getting in her brain? And are there other options she should consider?
So I think Nancy might be talking about a high-grade B-cell lymphoma. So I would assume like a very aggressive, like diffuse large B-cell lymphoma type cancer. And depending on kind of the extent of the cancer and what kind of cells that they see under the microscope, then standard of care often, so in addition to kind of other risk factors that a patient may have, which would include abnormalities on blood work, findings that they'd see on the bone marrow, the extent of disease that you would see on a CAT scan, then in certain cases, the risk of CNS involvement, which is brain and spinal cord involvement, would be elevated. And in those situations, it is recommended to get what we call prophylactic or chemotherapy to that area to prevent the spread of cancer to that area. So in certain situations, it is necessary, and it can actually keep you safe and prevent the cancer from going to those areas.
In alignment with the lymphoma question, Deborah's asking, are there medications that can cause lymphoma?
There are. So some medications which cause chronic immunosuppression can increase your risk for blood cancers. So those medications are often medicines that people with autoimmune disorders use, or medications that people with IBD, so like ulcerative colitis or Crohn's disease, or any medicines that kind of suppress your immune system might increase your risk for an underlying lymphoma or even leukemia. But kind of when patients make those decisions to take those medications, you have to weigh the risks of kind of what the effects of the autoimmune disease that you're dealing with is versus the potential small risk of getting a secondary cancer from it.
What advancements in your field are you getting are you having the most hope for?
Well, there's so many that it's hard to pick, and that's a good problem. But I think in terms of treatments, CLL, which stands for chronic lymphocytic leukemia, has a lot of really exciting treatments that are incredibly effective. They're indicated often for patients who have not responded well to previous therapies. So it's an opportunity to get long-lasting control for patients who previously might not have done very well. The targeted therapies that I mentioned in acute leukemias are exciting because they allow, non-chemotherapy type treatments for patients who may have progressed after chemotherapy. It gives them more opportunities to extend their life and control their disease. CAR T, we already mentioned, but I can't stress enough how exciting that is. And I think a lot of the monoclonal antibodies have a limited toxicity profile, but are allowing us to treat patients who maybe have been through a lot of chemotherapy and allow them to kind of get effective treatment without a lot of toxicities.
Should a patient consider experimental treatment options?
Yes, and I think that there's a place for that. So we touched on clinical trials already. I think that clinical trials are a great idea. I think that they're how we find new and excellent treatments for our patients, and I think that whenever you get a diagnosis, it's worth seeing what clinical trials are available to see if one sounds particularly promising. So within the realm of clinical trials, those are experimental drugs, and I think that depending on where you are in your cancer journey, it makes sense that to kind of consider that.
I think last question is, should I get a second opinion on my diagnosis?
My personal opinion for second opinions is that I think that I always encourage my patients to get second opinions. I think that it can offer a lot of peace of mind. I think it's invaluable to hear how somebody else might approach these diseases, because there's so much involved in them in terms of potentially long treatment courses, a lot of toxicities. A second opinion might offer you access to a different clinical trial than a doctor that you may be currently with. So I encourage all patients to get second opinions. Well, thank you for joining me today.